already just waiting for Professor Ahmed. So, how are you? Everything is good?
Yeah, everything is just super hot. How is in your country also hot?
No, in my city, it's a little bit moderate weather, not
Better.
very hot.
Mhm.
Yes, better. You are in
Mhm.
Nepal or where is it?
No, I'm in Turkey now, and it
In
is
Turkey.
in Ankara. Yes, it is super hot, 41
Uh,
degree, and the weather is super dry.
That's in the summer, it's like this actually.
Mm. But
Here
that's okay.
in my country, we have rain at the summer usually, so
Ah,
it make
rainy
weather,
season.
yes, so it become a little bit more tolerable.
Mm-hmm.
Yes,
Oh, I like rains.
yes, we all like that.
Mm. Mm.
Okay.
Everyone likes rains. My
Yeah.
daughter has also taken oath that whenever there is rain, you have to go with me downstairs.
Wow, great. No,
And
But
especially in South Asian countries, rainy season is like a magic. I
and
like.
yes, we went twice downstairs, and when we reached downstairs, there is no rain. So
There is
drizzling.
no rain. It's over.
Yeah.
maybe it take long time until you prepare the Torah. I will see if the Professor Riyad already with us or no.
Mhm.
Let's contact him. Today, Dr. Yusuf, we'll be talking about gross and microscopic anatomy of the cerebellum, yes?
Yes.
Okay. And then we will followed by Dr. Asad. He will talk about deep cerebellar nuclei anatomy.
Yes,
I hope it will get interesting topics, and I'm sure we will give a fantastic presentation.
inshallah,
Uh,
inshallah.
okay. Dr.
Sure.
Yusuf, you already participated with us before, yes? In module 2, I think.
Sorry?
Dr. Yusuf already participated with us in module 2 last time, I think.
No, I'm participating for the first time.
Um,
Yeah. Dr. Yusuf is the second time, yes, Dr. Yusuf?
Yes, I think second or third time. Second time as a speaker, but I've joined almost
Yes.
all sessions as a participant. These are very nice.
Yes. Thank you for joining us and supporting our program.
I like anatomy.
Yes, we all like anatomy, yes. It's the most
Yeah, but
important thing, yes.
yeah, liking anatomy is different. Understanding is completely different.
I
Yes, yes.
totally agree. I totally agree.
So
So I think maybe Dr. Muhammad Asman, can you hear me?
Yes, I can hear you. If the timing is running, maybe we can start.
Yes. Okay, so
Okay.
you can start the session, and when
okay,
Professor Riyad join, he can then catch up with us. Okay,
Okay.
so you can take the lead.
Okay. Thank you very much. I welcome all the participants to this second webinar of Comprehensive Neuroanatomy Educational Program, Module 3. So, as a neurosurgeon and as an expert in neurosciences or participants in neurosciences, it is very imperative to know the anatomy, especially the neuroanatomy. So, without any further delay, I would request our first speaker, Dr. Yusuf Sheikh, who's working as Assistant Professor of Neurosurgery at Liaquat National Hospital, Karachi, Pakistan, to talk on gross and microscopic anatomy of the cerebellum. Yes, please, Dr. Yusuf Sheikh.
Thank you, Dr. Swan. It's always an honor to present on this forum. And we'll be talking about the anatomy of the cerebellum with some surgical aspects to it as well. And I was informed that there'll be resident students as well. So I will try to go slow. And I think it's better that rather than finishing it off and not getting anything, it's better that we go slow and get something out of this session so that we can remember. So to begin with, we know that the cerebellum is situated in the posterior fossa, and for descriptive terminology or description, we divide it into three surfaces. The first is the first cortical surface, that is the tentorial surface. It faces the undersurface of the tentorium, and this is generally the part that we retract when we're doing a supracerebellar approach. Then the second surface is the suboccipital surface that is situated posterior inferiorly. And this is situated between the sigmoid sinuses and below the lateral sinuses. And this is one of the most common sites for approach for suboccipital craniotomies and approaches to fourth ventricles. The third surface is the petrosal surface, which is situated anteriorly. It faces the petrous part of the bone, and this is the general area that we access during approach to CP angle tumors that we frequently do, such as acoustic neuromas or dermoids, epidermoids. Now, each of these surfaces has a bilateral cerebellar hemisphere and a central midline structure, which is known as the vermis. And today what we are going to do is that we'll discuss each surface one by one, and then we'll go on to the deeper dissection on these surfaces so that we can understand the other structures attributed or beneath the surface anatomy, including all fissures and various parts of it. So, first of all, the tentorial surface. Now, as I said that I have mentioned that this is the tentorial surface which faces the undersurface of the tentorium. Now this part, which is the anterior-medial part, this part that is the anterior-medial part of the tentorial surface is referred to as the apex. This is the part of the vermis which is the highest point of the cerebellum. So if you look at it in the sagittal section, it will be the highest part of the cerebellum. So we refer to as the apex. Now on this surface, you can appreciate that the transition from cerebellar hemisphere to the vermis and then the cerebellar hemisphere is relatively smooth. There are fissures which go on in a continuous fashion, and there is a gradual transition. So you can't actually demarcate that on the tentorial surface, the vermis is separate or the hemisphere is separate, because on this surface, there is no demarcating fissure between the vermis and the cerebellar hemisphere. However, they do have certain notches. This V-shaped structure is the anterior cerebellar notch, you all can appreciate. And posteriorly, we have this depression known as the posterior cerebellar notch. You can see that the anterior cerebellar notch is housing or facing the brainstem and is an important structure forming a posterior wall of the cerebromedullary fissure. Whereas the posterior cerebellar incisura, this depression, contains predominantly the falx cerebellum. So the anterior cerebellar incisura houses the brainstem, predominantly the midbrain, and the posterior cerebellar incisura houses the falx cerebellum. Now we go on to the borders. This is the anterior and anterolateral medial border of the tentorial surface that separates it from the petrosal surface. So this border is divided into two parts. This part is known as the anterior-medial border, and this part laterally is known as the anterolateral border. The anteromedial border, as I mentioned, is facing the midbrain, whereas the anterolateral border, this part, it tends to face the superior petrosal sinus. And the part where the anterolateral border and anteromedial border meet, this angle is known as the anterior angle. The clinical and surgical importance of this anterior angle is that this is just above, this area is just above the origin of the posterior root of trigeminal nerve. So this is the anteromedial border, and this is the anterolateral border, and its union is known as the anterior angle, which is just above the origin of the posterior root of fifth cranial nerve. Similarly, it has a posterior border. This is a posterior border. And again, Croton says that we have divided into two parts, the medial part and the lateral part, this lateral part. The lateral part runs parallel to the lateral sinus, and the medial part, as you can see here, faces the posterior cerebellar incisure. And just like the anteromedial lateral border, the posteriolateral and posterior-medial border meet here. This angle, this is known as the lateral angle, and lateral angle is the site where the lateral sinus, sigmoid sinus, and superior petrosal sinus will meet. So both of these angles have surgical importance because of the origin of the structures. Over here, the fifth cranial nerve rises, and over here, it is the union of the venous sinuses. Now, moving on to the hemispheric surface, you can see that on the hemisphere, there are various structures. These include the most important quadrangular lobe. Then beneath it, we have simple lobule. And then beneath that, we have the superior semilunar lobule. Similarly, the vermis has three parts: culmen, declive, and folium. So Croton says that each vermis, because as I mentioned, the hemisphere and the vermis are in more or less continuity with each other on the tentorial surface, the vermion and its representative hemispheric part from anterior to posterior are the culmen and quadrangular lobule, declive and simple lobule, folium and superior semilunar. Moving on to the fissures, the tentorial surface has a primary fissure known as the tentorial fissure. You can appreciate that this is the tentorial fissure, which is roughly dividing it into anterior tentorial surface and posterior tentorial surface. The anterior tentorial surface is just made up of quadrangular lobule, whereas the posterior tentorial surface is further subdivided by a postclaval fissure into simple lobule anteriorly and superior semilunar lobule posteriorly. Then, in addition to these major dividing fissures, you have these smaller fissures, smaller ones, which then from the quadrangular surface turn anteriorly and inferiorly onto the petrosal surface. So some of these fissures are continuous onto the adjacent surface as well. So this is about the tentorial surface. We'll be digging deeper in the later stages, but first we'll cover the surface anatomy of all surfaces. So this is all the text that is written, but I tried to explain it on the pictures, and I'll continue to explain on the pictures and read minimal text as possible. Suboccipital surface. Now, suboccipital surface is probably relatively, it's not complex, but it is relatively more complex than the other surfaces, and it is probably the most important to understand. This is the reason because most of our approaches to the fourth ventricle or tumor is directed through the suboccipital surface. And the suboccipital surface, as I mentioned, is the one between the sigmoid sinuses and below the lateral sinuses. So to begin with, the suboccipital surface has this vertical depression in the midline. You can appreciate this is the cerebellum, but as you can appreciate this angle, so this is a vertical depression. And as I mentioned, this is the inferior continuation of posterior cerebellar incisura. So this is posterior cerebellar incisura. And I have stated previously that it contains the falx cerebelli. Now, the dural folds then go on to the vermis as well. So this is the vermis. And vermis, unlike the tentorial surface, is separated from the cerebellar hemisphere. So the posterior cerebellar incisura over here has lateral walls, which are made up of cerebellar hemispheres. And vermis over here is separated from the cerebellar hemispheres by these two parallel fissures, which are known as vermio-hemispheric fissures. Okay. There were no demarcating fissures on the tentorial surface, but on the suboccipital surface, there are visible fissures, these two, on each side. So now if you look at the vermis over here, the vermis has four parts: folium, tuber, pyramid, and uvula. And this part of the vermis is said to be diamond in shape. So you all can see my mouse movements, right? Okay, so this is diamond shape. So Roton says that we have divided this diamond into upper half and this lower half. Because this upper half resembles the shape of a pyramid, it is known as pyramid. And this is also the widest portion of the vermis on the suboccipital surface. The vermis is widest over here. The lower half is formed by the uvula, and the reason it is called uvula is just because it resembles the uvula of the oropharynx. It tends to hang in between the tonsils. And in this case, they are referred to as tonsils as well. So this is the uvula. Just above the pyramid is the folium and tuber. Okay, so I've mentioned this is diamond in shape, and then we move on to the cerebellar hemispheres. If you look at the vermis as well, there is a part of vermis which you cannot see, that is known as the nodule. Now, nodule is located deeper to the uvula. So until unless we remove the uvula, we will not see the nodule. But in the subsequent slides, when we will dig deeper into the dissection, I will show you the nodule and what is its important clinical significance. So, inferiorly, if we continue to go down, then this posterior cerebellar incisura opens into vallicula cerebelli, which drains into the fourth ventricle via foramen of Magendie. So similarly, each part of the vermis has a corresponding representative hemispheric structure. So the folium correlates to superior semilunar lobule, tuber correlates to inferior semilunar lobule, pyramid correlates to biventricular lobule, and uvula correlates to the tonsillar portion. Now, just like the tentorial surface, the suboccipital surface also has a major fissure, which is known as suboccipital fissure. This is just one fissure, but yet again, we have divided into two parts: the hemispheric part and the vermian part. The vermian part is separating the tuber and pyramid, whereas the hemispheric part is separating the inferior semilunar lobule from the biventricular lobule. And then there is also another fissure known as petrosal fissure. Now, this is primarily a fissure of the petrosal surface. It actually turns on the suboccipital surface and it creates the superior and inferior semilunar lobules. This petrosal fissure, superior and inferior semilunar lobules. Now, the most important structure on this surface is predominantly the tonsils. These are the tonsils. Now, these tonsils are sort of overhanging or blocking the entry of the fourth ventricle. And they are roughly ovoid in shape, or you can say they are bean shaped like that. And they are attached to the cerebellum by means of a peduncle. So these are the tonsils. They are attached to the cerebellar hemisphere by means of a peduncle. Even though on the lateral surface it seems continuous, but it is said that it is separated from biventricular lobule by means of a fissure. They have not yet named the fissure, but there is a fissure or a narrow cleft. So the inferior surface of the tonsil and the posterior surface. The inferior pole and posterior surface faces the cisterna magna over here. The anterior surface of the tonsil, that is on the rostral aspect, it faces the medulla to form the cerebellomedullary fissure. The medial surface are in proximity to each other, that is the medial surface of the tonsils are projecting onto each other towards the vallicula leading to the fourth ventricle. And the ventral aspect, that is the rostral aspect, it has three very important structures. Okay, we'll be digging deeper, so I'll show you the slides configurations later. But understanding that the rostral, ventral to the superior pole of tonsil are the three most important structures: the inferior medullary vellum, tila choroidi, and the nodule, which I mentioned is the part of the vermis located just beneath the uvula. And these three structures form the lower half of the roof of the fourth ventricle. And these are the 4-5 structures over whom the entire approach to the fourth ventricle and suboccipital craniotomies are laid out. So this is all what I have described. Tonsils, I have described their surfaces: the medial surface, the lateral surface, inferior pole, and most importantly, the ventral aspect. The ventral aspect of superior pole of each tonsils faces three structures: tila choroidi, inferior medullary vellum, and nodule, forming the roof of the fourth ventricle. This is the important aspect. Finally, we move on to the petrosal surface. Now we know that petrosal surface is the anterior most surface. So we have rotated the brainstem. So now we are looking at it anteriorly. So it faces the brainstem, petrous, and fourth ventricle. It also has a deep anterior depression in which this brainstem is located. So the posterior surface has a vertical depression that was posterior cerebellar incisura. This is anterior cerebellar incisura, which is containing the brainstem, that is the midbrain, pons, and medulla oblongata. Now, unlike the other surfaces, the cerebellar hemispheres over here are not connected to each other directly. This is because the fourth ventricle is intersposed here in the deeper midline. So the cerebellar hemispheres are not connected to each other over here. And it has a very major fissure that is known as petrosal fissure, dividing the superior and inferior semilunar lobules. And this petrosal fissure has an anterior limb and a posterior limb. That is a superior part of the petrosal fissure and inferior part of the petrosal fissure, and this is known as the angle. That is the formation. Now these fissures are important because almost all the cranial nerves are originating from these fissures. So we'll be coming to that as well. And each hemisphere has the wings of the central lobule plus the semilunar and inferior semilunar lobules. Now, what we'll do is we'll go into the deeper dissection of the surfaces one by one. We first talked about the tentorial surface. So, and we said that this is the anterior medial border and this is the anterior cerebellar incisura housing the brainstem. So the upper part of the tentorial surface surrounds the posterior half of the midbrain and forms the cerebellomesencephalic fissure. This is the cerebellomesencephalic fissure. And it contains the brainstem, which I've said. We have removed some part of the brain over here, so you can appreciate that the medial border is formed by the culmen, whereas the lateral border is formed by the quadrangular lobule. Now, these are the borders of the posterior wall of cerebellomesencephalic fissure. Okay, so this is a cerebellomesencephalic fissure, and its posterior lip is bordered by the quadrangular lobule laterally and medially by the culm. And just rostral or anterior to it over here is the quadrigeminal cistern that extends from the pineal area down to the cerebellomesencephalic fissure. Okay, next picture. This is the same picture. We have just rotated the angle. Okay, so let me just, this is looking at it from the midline, and now we have rotated it. Now we have rotated it slightly. And what we have done is that this was the anterior cerebellar incisura and this was the culmen. So what we have done is we have cut half of the culmen and removed the quadrangular lobule. So you can see that this is the central lobule. Because we are dissecting deeper onto the from the tentorial surface, so we are heading more towards the petrosal surface. Okay, so this is the central lobule, and these are the wings of the central lobule. And again, these are the components forming the posterior wall of the cerebellomesencephalic fissure as you go laterally. Now we will remove this as well. We have removed the central lobule and its lateral wings, the midline lingula, the superior medullary velum. And over here, we have also removed some part of the superior peduncle. So what you see over here in the midline is the nodule. And as I mentioned, nodule is the deepest part of the vermis that is located deeper. So we have to remove part of structures to appreciate the nodule. Over here, we have the inferior medullary velum. This part is known as the tila choroidea, and these structures together are forming the part of the fourth ventricle. So you can appreciate the nodule, the inferior medullary velum, and this part is known as the tila choroidea. Now we have removed some part of over here in this diagram, the middle cerebral peduncle as well. So you can see that how the choroid plexus are entering through the lateral recess into the CP angle just around the 7th and 8th cranial nerve over here. And now we are going to rotate it yet again, the same picture. This is the nodule. This is the inferior medullary velum. This is the tila choroidea. This is the choroid plexus that is running along the lateral wall along with the 7th and 8th cranial nerve. And this inferior medullary velum, which is arising from the surface of the nodule, extends laterally underneath the middle peduncle to the flocculus, forming the flocculonodular lobe of cerebellum, this structure. Okay, this is the flocculonodular lobe. Now, moving on to the occipital surface. I have already described the surface anatomy, and the important structure over here is this cerebellomedullary fissure. That is just beneath the tonsils. Over here is the cerebellomedullary fissure between the cerebellum and medulla along the inferior half of the ventricular roof. And this over here is the vallicula, which is between the tonsils and communicates with the fourth ventricle through foramen of Magendie. This is the folium, tuber, pyramid, uvula. These are the tonsils. This is the foramen of Magendie from the vallicula to the fourth ventricle. And deeper to uvula, what we will find? Nodule. What we have done is that this is the normal anatomy that we have seen. We have retracted the tonsil. I think everyone can appreciate that this is the retractor. We have retracted the tonsil. So the right tonsil has been retracted to expose the lower part of the roof of the fourth ventricle. And what you can see, the same structures, that is tila choroidea, inferior medullary velum. Inferior medullary velum, tila choroidea. And this is the junction between the two. And this is the reason that what we do, the tilovelar approach, is because it is the junction of the inferior medullary velum and tila choroidea, so it is known as tilovelar approach. So nodule over here is yet again hidden by the tonsils. Once I will remove the tonsil, we will appreciate the nodule over here in the midline. The choroid plexus you can appreciate over here arising from the inner surface of the tila and extends through the foramen of Luschka behind the glossopharyngeal and vagus nerves. This over here, choroid plexus, it enters via the foramen of Luschka into the towards the fourth ventricle. The inferior medullary velum arises on the surface of nodule and it drapes along the superior pole of the tonsil. So this tonsil has been retracted. In the next picture, we will retract both tonsils. So now it becomes bilaterally symmetrical. Yet again, the uvula and both the tonsils. This tonsil has been retracted, and you can very clearly appreciate the symmetrical tilovelar junction. This is the inferior medullary velum, this is the tila choroidea, and this is the tilovelar junction. And this rhomboid lip. Now it is like a sheet of neural tissue which is attached to the lateral margin of the ventricular floor, and it is posterior to the glossopharyngeal and vagus nerves and joins the tila choroidea to form an outpouching over here. So I did not understand this part clearly for some reason, but this is what is most important, tilovelar junction. Now what we will do is we will remove the right half of the tila, and now that we have removed the tila choroidea, we have exposed the lateral recess and the fourth ventricle. The inferior medullary velum over here, you can appreciate it extends laterally to form the peduncle over here, and peduncle to the flocculus, which blends into the flocculus at the outer margin of the lateral recess. Inferior medullary velum, peduncle, and then the flocculus. And this is the entry to the fourth ventricle. We have removed both the tila choroidea in this diagram, and you can clearly appreciate the lateral walls of the fourth ventricle, which are formed by superior cerebellar peduncles. And this is the opening to the fourth ventricle, which will be used for accessing or removing tumors via tilovelar junction. So this was about the deeper dissection on the suboccipital surface. Now, finally, the deeper dissection of petrosal surface. Now, the important things that we're going to talk about is the petrosal fissure. The petrosal fissure is a V-shaped fissure, and it has a anterior limb, or which is the superior limb, or the inferior limb. This inferior limb and this superior limb meets over here, which is known as the apex, and they form a petrosal fissure combined. Cranial nerves 5 through 11 arise from the margins of this cerebellopontine fissure. And we all know this is the basilar sulcus, which contains the basilar artery, and the flocculus and choroid plexus extend laterally by the foramen of Magendie above the lower limb of this fissure. Again, a magnified view of this surface, that is the petrosal surface, which showing the petrosal fissure. This is the petrosal fissure. The apex of the cerebellopontine fissure with its superior limb and inferior limb. The abducens nerve, that is the sixth nerve, here it is. It arises in the medial part of the pontomedullary sulcus. Then we have the seventh and eighth cranial nerve, these ones, which arise just rostral to the foramen of Luschka and lateral to the pontomedullary sulcus. So medial to the pontomedullary sulcus was sixth. 7 and 8 are lateral to the pontomedullary sulcus, because this is the pontomedullary sulcus, we can all appreciate. And hypoglossal nerve arises anterior to the glossopharyngeal vagus and accessory nerve. This is the 12th cranial nerve, which is anterior to the glossopharyngeal vagus and other cranial nerve. And choroid plexus, it is often used as a surgical landmark as well, which travels along with the glossopharyngeal and vagus through the foramen of Luschka. This is generally what we see in tumors such as ependymomas, because they tend to arise from the floor of the fourth ventricle, predominantly involving the foramen flesh as well. Yet again, a very magnified view and clearer picture of the same area, showing the apex of the cerebellomedullary cerebellopontine fissure. Then we have the glossopharyngeal nerve, vagus and accessory nerves arising from the inferior limb of the cerebellopontine fissure. So we have this 10th cranial nerve, that is the vagus nerve. The 7th and 8th nerve, these two are arising in the mid portion of the fissure near the trigeminal nerve, and the hypoglossal nerve arise in front of the over here. The hypoglossal nerves arises over here in front of the olives. So that was most of it about the surface anatomy of the cerebellum. And if we go deeper, we have identified the various structures and the various fissures and the surgical anatomy. But yet again, the most important structure or the most important surface is the suboccipital surface, because generally the supracerebellar approach is restricted to tumors of the pineal area, which are not that common. And yet again, CP angle tumors, you do well, which is easy to approach, but approaches to the fourth ventricle are most important. So again, this is just a picture of the roton showing that how we are retracting in an operative view or during a surgery, how you will retract the cerebellar tonsils to expose the tila. This is the uvula. And then you retract the tonsils to expose the telovelar junction, inframedullary velum, and then you open that to expose the tumor. And this is the telochoroidea. So that is probably it from the presentation. And I hope it was not very difficult, or on the contrary, not very easy as well. So I hope it was beneficial for all of us. Any questions regarding the anatomy?
Yeah, thank you very much, Dr. Yusuf. I must say, very excellent talk on the gross and microscopic anatomy. There is a question in the chat box from Hafsa Mahmood, and that is nodule is behind folium or decline?
Nodule is just behind the uvula. Behind the uvula. So you have to remove the uvula to appreciate the nodule.
Okay, thank you. Anybody want to ask something? Any questions? Okay, if there is any question, you can type in the chat box. Maybe if the time allow, we will discuss at the end of the second talk. Thank you once again, Dr. Yusuf.
Thank you,
Now,
Dr.
I would like to,
Dr. Riaz,
yeah. I think Professor Riaz Ahmad Raja, the President of Pakistan Society of Neurosurgeon, is here. Sir, if you want to
Assalamu alaikum
comment
and
or
thank you so much. Hi, everyone. And it was really a nice talk from Dr. Yusuf. And the topic was very complex. Always a posterior fossa is a very complex topic, and having a lot of the things and to learn in the posterior fossa, CP angle, the midline tumor, the supracerebellar, craniovertebral. So I think he has fulfilled and captured all the topics, and gave a very nice talk on the topic of the cerebellum. So I would like that more emphasis should be given to the surgical oriented, particularly the tumors and the AVMs and what are the other neurosurgical procedures, so that our juniors can learn more from the more surgically oriented neuroanatomy. So thank you so much, Dr. Yusuf, and thank you so much, Ahmed, Ahmed Sadeh. So I think over to you, Dr. Osman, for the next talk.
Okay, thank you for the nice comment and the suggestions. Now we'll move towards our second talk, and the presenter is Dr. Asad Ismaili. He's the Registrar Neuro and Spinal Surgery Department at JPMC Karachi, and he will be discussing the deep cerebellar nuclei, anatomy and functional pathways, afferent and efferent pathways. So, Dr. Asad Ismaili, over to you.
Thanks a lot, everyone. So you can hear me loud and clear, right?
Yes.
Okay, once again, thanks for inviting me on this forum. I especially want to thank Professor Dr. Riaz Raja, Dr. Usman, Dr. Ahmed, and our today's presenter, Dr. Yusuf, once again. And again, it's a privilege and honor to present on such forums. So today, the topic given to me was it was about cerebellar nuclei, anatomy, and the functional pathways. So again, I would refer to the statement given in the beginning of this talk by Dr. Yusuf. Okay, loving anatomy is something different, and understanding anatomy is something different or totally different. So I would like to start with my talk, and I would like to keep it simple. I would like to show you more of the illustrations and diagrams so that the cerebellar nuclei, its anatomy, and the functional pathways should be embedded in our minds, and this talk will surely benefit each and every one of us. I will also go through some gross anatomy as well, because without discussing the gross anatomy, you cannot even discuss anything about the cerebellar nuclei, its anatomy, and the functional pathways. So as we all know, the cerebellum, we can call it the organ of three. Why we call it the organ of three? Because it has three anatomical lobes. It has three phylogenetical divisions. So what is phylogenetical divisions? When we talk about phylogenetic, it means development according to the age of the cerebellum. Because if we divide phylogenetically, cerebellum, it has three types or three classifications, and each classification or each part has different aging. So we will also discuss about these as well. It has three main features, as already discussed by Dr. Yusuf. We will also discuss about the three functional zones. So anatomical landmarks are different and the functional landmarks are different. So we will try to keep it very, very simple so that we can take more from this lecture today. Again, we have three peduncles, three histological layers, three arteries in each hemispheres, and symptoms explained by three zones. So grossly, again, we have two lateral hemispheres, and they are connected by a narrow portion called the vermis, which is already discussed in detail. It is in the midline. It has three surfaces like tentorial, suboccipital, and the petrosal surface. The external surface, called the cerebellar cortex, is composed of small folds, and we call these folds as foli, separated by sulci. The cerebellar surface again is divided by numerous curved and transverse fissures, giving it a laminated appearance. Okay, now let's talk about the divisions. So we have divided the cerebellum into the anterior lobe, and in the anterior lobe we can have lingula, centralis, and the culmen, already discussed by Dr. Yusuf in the anatomy. We have posterior lobe, which has simplex, declive, folium, tuber, ensiform lobe, paramedian lobe, and the last one is the flocculonodular lobe, which has pyramid, uvula, nodule, and the flocculus. Now the subdivision of the cerebellar hemispheres and the vermis. So we already have discussed that the part of the vermis, it is located in the midline. So in the midline, if we follow the vermis from top to bottom, we have lingula, central lobule, culmen, declive, folium, tuber, pyramid, uvula, and finally the nodule. And as we move laterally, as we move in the periphery from the vermis, then we can have subdivisions of the cerebellum, and we can call it like ala, quadrangular lobule, simple lobule, superior semilunar lobule, inferior lobule, biventral lobule, tonsils, and finally flocculus. Now this is the again superior surface of the cerebellum. We have used 3 to 4 colors, like the red one in the midline is the vermis. The upper portion is the central lobule of the vermis, the culmen of the superior vermis. And as we move laterally, we have quadrangular lobule in the hemisphere. And these are separated by the primary fissures. As we move in the midline again downward, we have declive, folium, and the posterior cerebellar notch. So when we see cerebellum from the superior surface, it appears like this. In the second diagram, this is the inferior surface of the cerebellum. So we can see from the top portion, the central lobule of the superior vermis, and the lingula of the superior vermis is visible. And then the important structure is again the superior medullary vellum. In the periphery of the superior medullary vellum, we can see the 3 peduncles, the superior, the inferior, and the middle cerebellar peduncle. And we all know from these peduncles, the cerebellum is relaying information to other structures of the brain. For example, the superior cerebellar is going to the midbrain, the middle cerebellar is going to the pons, the inferior cerebellum is going to the medulla. Now, this is this opening is the 4th ventricle. It's a tent-shaped cavity, and just beneath it is the inferior medullary vellum. And when we move downward, we have nodule, inferior vermis, uvula, pyramid, tuber, and the posterior cerebellar notch. So this is about the gross anatomy from the superior and the inferior surface. It will also help us in going forward in our discussion. So as I've discussed, the phylogenetical classification according to the development. This is important because if we know these things, then we can understand the tracts which are coming in and going out from the cerebellum, and the amount of work they are doing, the main function they are performing. So the first one is the archicerebellum. We also call it vestibulocerebellum. And this is the oldest portion of the cerebellum, the senior most portion of the cerebellum, I may say. And what does it contain? It contains flocculonodular lobe, the lingula, and the associated fastigial nuclei. So again, we have to remember this: flocculonodular lobe, the lingula, and the fastigial nuclei. They are present in the phylogenetic classification of the archicerebellum, or we may call it vestibulocerebellum. So they have connections, and where do they connect? They connect with the vestibular and the reticular nuclei. And how they connect? They connect through the inferior cerebellar peduncle. And they also receive afferent fibers from the vestibulocerebellar tract. So main function of the archicerebellum, the oldest portion of the cerebellum, is to maintain the equilibrium. And equilibrium is the most important function which this little brain, we also call it cerebellum, has to perform. As we move further in the phylogenetic classification, we have paleocerebellum. We also call it spinocerebellum. So as the name suggests, spinocerebellum, so it has some connection with the spinal cord. This will make it further more easy. This is the second part of the cerebellum which appears phylogenetically. The first is the archicerebellum. The second one is the paleo or spinocerebellum. So what does this contain? It contains anterior lobe, except for the lingula because it is included in the archicerebellum. It contains pyramids. Sorry, this is a spelling mistake, not pyramis, it's pyramid, and uvula of the inferior vermis, and associated globus and emboliform nuclei. So the spinocerebellum is composed of the anterior lobe except limbula, the pyramid and uvula of the inferior vermis, plus globose and emboliform nuclei. So what does it receive? It receives afferent proprioceptive impulses from the muscles, tendon, and how they arrive? They arrive through the spinocerebellar tract. And again, we all know the spinocerebellar tract has dorsal and ventral portion as well. And the efferents via superior cerebellar peduncle, they give rise to descending rubrospinal tract. And this part is concerned with muscle tone and posture. So RC cerebellum, which was the first part, it was related to the equilibrium. The paleocerebellum or the spinocerebellum is concerned with the muscle tone and posture. So you cannot attain equilibrium without having a good posture and an appropriate muscle tone. Now the third portion, which is the newest portion, phylogenetically or age-wise, is the cerebellum or the pontocerebellum. We call it neocerebellum. So if I say how to remember it, you can say this is the newest one, neocerebellum. So this is the largest portion of the cerebellum and the newest part to develop. And what does it include? It includes cerebellar hemispheres, mainly the posterior lobe, plus dentate nuclei. So the major chunk of the cerebellum resides in this neocerebellum, which is the newest part of the cerebellum, and it includes cerebral hemispheres, mainly posterior lobe, plus dentate nuclei. And it also receives impulses from the cerebral cortex plus pons. And how does it receive? It receives through the cerebro-pontocerebellar pathway, through the middle cerebellar peduncle, and it also sends efferent to ventrolateral nucleus of the thalamus, which controls the motor activity. So what does it control? It controls the voluntary movement, the muscle coordination. So again, the RC cerebellum is responsible for the equilibrium. The spinocerebellum or the paleocerebellum is responsible for the muscle tone and posture. And the last one to arise, the neocerebellum, the newest portion, the largest portion of the cerebellum, it controls the voluntary movements like muscle coordination. Now let's divide cerebellum in the functional division. So we can divide cerebellum in 3 longitudinal zones. These are the functional divisions of the cerebellum. In the midline, you can see we have the vermis, the medial zone. It is concerned with the control of the long axis of the body. You can call it in the axial portion, the midline portion, mainly the extensor muscles of the neck, head, shoulder, thorax, hip, abdomen. All the structures which lie in the midline are controlled by this midline vermis, the median zone. And the second one is the intermediate zone. Just next to it, it is concerned with the control of the muscles of the distal part of the limb, especially the flexor group, or you can call it appendicular portion away from the midline. But we have to remember that it controls the flexor group, especially the distal parts of the limb. And the last one is the lateral zone. So what does it do? It is connected with association areas of the brain, and they help in the planning, programming, and coordination of sequential movement of entire body. And it also assesses the conscious assessment of movement error. So these are the 3 functional divisions, the median, intermediate, and the lateral zone. Now, as far as the histology of the cerebellum is concerned, so you can see the cerebellum has the outer covering, which has its gray matter called the cortex, and the inner layer of the white matter, which is called the medulla. So the gray matter is outside, the white matter is inside in case of cerebellum, and the gray matter is dipping like projected fibers or finger-like projections into the deep portion of the cerebellum, and white tract and medulla is running like branching tree, which we call as arbor vitae cerebelli, which is a Latin word and which literally means tree of life, because it resembles the branching pattern of a tree. Now, deep inside the cerebellum, we have 4 nuclei, namely the fastigial nuclei, the globose nuclei, the emboliform, and the dentate nuclei. So cerebellar cortex, the outer layer of the cerebellum, we will divide it again in 3 layers: the molecular, Purkinje, and the granular layer. So this is the MPG, molecular layer, Purkinje cell layer, and the granular layer. What type of neurons do they have? They have 5 types of neurons, which we have to know: the Purkinje neurons, the basket cells, the stellate cells, the Golgi cells, and the granular layer is the excitatory one. So we have to remember these things in order to know about the deep cerebellar nuclei and the functional pathways. Now we all know about this mnemonic in order to memorize the deep cerebellar nuclei. So don't eat greasy food. It's a life hack as well. Everyone has to follow this, but you have to remember the deep nuclei of the cerebellum by remembering this mnemonic, as we have already gone through it in our previous years. So starting from lateral to medial, the largest one is the dentate nucleus. Then we have nucleus interpositus, which have 2 types like emboliform and globose. And the middle one is fastigial nucleus. From lateral to medial, don't eat greasy food: dentate, emboliform, globose, and fastigial nucleus. Now the cerebral cortex. Now we will move a bit more quicker because we have to know these things so that the mechanism should be known. The molecular layer, the top one, we have a stellate cell, which has efferent parallel fibers and afferent parallel fibers and the efferent Purkinje cells, dendrites. Then the second one, we have the basket cells. They are the inhibitory neurons, and parallel fibers, which has granule cell axons, and the Purkinje dendrite cell. The Purkinje cell is not present in the molecular layer, but it is ending up its dendrite into the molecular or the outermost layer. Now, the second layer is the Purkinje layer. It is numerous in number, like more than 150 lakh. The main function is inhibitory. The afferent parallel fibers and the climbing fibers, stellate cells and basket cells are present. Mostly the stellate cells, the basket cell, they act as interneurons and connect the inner and the outer layers. So this is the diagram of the Purkinje cells. They are flask-shaped cells. They have a spicule. They have branching pattern. They have dendritic spines. The third layer is a granular layer. Again, very, very important layer. It has more than 50 billion in number, the number of the cells, and it is excitatory in nature. So afferent, they are controlled by the mossy fibers. And efferent connections are from the Purkinje cells, axon, basket, stellate, and the Golgi cells. Again, Golgi cells are inhibitory, same as the Purkinje cells. So granular layer mostly releases excitatory signals that goes up into the outermost layer. Through the parallel fibers, it goes and the excitation begins. So we also have climbing fibers. As the name suggests, they are climbing from downwards. So where are they coming from? They are coming from the inferior olivary nucleus from the medulla. And the direct action on the Purkinje cells, they are very powerful, sharply localized. The second ones are the mossy fibers. They are coming from the spinal cord and some portions of the brainstem as well. So they indirectly act on the Purkinje cells through granular cells. Now let's talk about the white matter of the cerebellum. So this is basically the internal circuit of the cerebellum. These are the important points we have to remember before going into the white matters of the cerebellum. So these are some principles which the white matters of the cerebellum follows. The first one, they do not leave the cerebellum, interconnect different regions of the cerebellum. So they reside in the cerebellum, they connect different portions of the cerebellum. Some of them connect the same side, some connect to the opposite cerebral hemisphere as well. The cerebellar efferent is via middle cerebellar peduncle and inferior cerebellar peduncle. So efferent fibers are coming from the middle and inferior cerebellar peduncle, whereas the cerebellar afferent fibers are coming from the superior cerebellar peduncle and from fastigial nuclei from inferior cerebellar peduncle. So the white matter, we have to remember the mnemonic PMC. PMC means the Purkinje cells axons. M is the mossy fiber and C are the climbing fiber. So we have to remember that these are the neurons which are present in the white matter, and they have different works. Like Purkinje cell axons, they arrive from the deep cerebellar nuclei, especially the dentate nucleus. What are mossy fibers doing? They end in the granular layer, and climbing fiber, they end in the molecular layer. So again, they are divided into three groups: intrinsic fibers, afferent fibers, and efferent fibers. So again, I repeat, intrinsic fibers, afferent fibers, and efferent fibers. So this slide is very, very important, and this will actually tell us how cerebellum is working. I want to give an example. If someone is driving a car and that guy is pushing the accelerator, what happens if you push the accelerator full throttle and you are not able to lift your leg? So this is all coordinated movement which has to be stopped at some stance, like pushing of the accelerator has to be stopped. How does it stop? How much it has to be stopped? So it also depends upon the coordination, equilibrium, muscle tone, which is again controlled by the cerebellum, especially the intrinsic system of the cerebellum. So what does the intrinsic cerebellar circuit is all about? So we have to remember feed forward inhibition of the Purkinje cells. So this is very interesting. You can see this diagram. So this is the deep nuclei. This is the Purkinje cell. This is the basket cell. These purple shaped structures are the parallel fibers. This purple is the granular cell, and this is again the Golgi cells. Mossy fibers are climbing upstairs, and these are the positive ones. So they are excitatory. All the input to the deep cerebellar nuclei are mostly excitatory, except for the Purkinje fiber, which has the inhibitory effect. So you can see the basket and the stellate cells, they are excited by granule cells by the parallel fibers. So this is the basket cells. You can see my cursor. And the stellate cells, they are excited by the granular cells. So granular cell is giving signals to the basket cells and the stellate cells, and these are the excitatory signals. In return, the basket cells and the stellate cell, they inhibit the Purkinje cells. See, the primary input is excitatory. It goes to the granular cells and then to the basket cells and the stellate cell. They excite it. In the same phase, the basket cell give inhibitory signal to the Purkinje cells to stop the excitation. So this is how cerebellum works. Single excitatory stimulus can go upward, excites everything, and similarly, the same signal is inhibiting through the Purkinje fibers. The Purkinje cell and the basket cells are excited by the same excitatory input. This arrangement is called feed forward inhibition. So one input is there, it is excitatory in nature as well as inhibitory in nature. So this is how coordination is working in the cerebellum intrinsically. This helps to limit the duration of excitation produced by given afferent impulses. Now the second one is feed forward inhibition of the granule cells. The first one was feed forward inhibition by the Purkinje cells, and the second one is the inhibition of the granule cell. The working principle is same. The mossy fibers stimulate the granule cells. See, this is the mossy fiber. They are stimulating the granule cells. The mossy fibers also excites Golgi cells. So this is the mossy fiber. which has excited the granule cell, and it has also excited the Golgi cell. Now the Golgi cell inhibits the granular cells. In return, this positive excitatory input towards the Golgi cell resulted in a negative input from the Golgi cell to the granule cells. So excitatory input is 1. It is causing excitation at this level, and similarly in return, this Golgi cell is giving a negative inhibitory signal to the granular cell. So excitation as well as inhibition simultaneously it is occurring in equilibrium. Since the granule cell and the Golgi cells are excited by the same excitatory input from the mossy fibers. So this arrangement is said to produce feed-forward inhibition of the granule cells. Now, similarly, the feedback inhibition of the granule cell. The granule cell is excited by the mossy fibers, and the axon granule excite the Golgi cell dendrites, whose axon inhibits the granule cell. So see, this circuit keeps on going and going. So one excitatory signal is exciting a single cell. That single cell in return is giving an inhibitory signal. So in this manner, the intrinsic pathway is responsible for maintaining the equilibrium in the body. Now let's talk about the afferent pathways. So when we talk about the afferent pathways, so afferent pathways are the incoming pathways. So cerebellar afferents are divided into 3 main sources. We will discuss the source because there are so many tracks and so many pathways. We will stick to the most important ones. So 3 main sources are there from the cerebral cortex, from spinal cord, from vestibular nerve, and small number of afferent originate in the red nucleus and the tectum as well. Now talk about the cortical projections. So before reaching the cerebellum, the cortical projections establish synaptic contacts with 3 brainstem structure, mainly pontine nuclei, the inferior olivary nuclei, and the reticular formation. So all the afferent projection from the cortex, from the higher centers of the brain, they reach and synapse contacts with 3 brainstem structure, mainly pontine, inferior olivary nucleus, and the reticular formation. So this is the cerebral cortex. The track is projecting towards the pontine, reticular formation, and from the inferior olivary nucleus. Now let's talk about the afferent pathways of the cerebellum and their function. So we have to remember this table because this table is very, very important. And for the purpose of simplicity, I have placed 3 diagrams on the rightmost corner of these tables. So the first corner, we have cerebrum. So you can call it cerebral cortex. The second diagram is of the spinal cord cut section. And the third diagram is of the hearing mechanism or the balancing mechanism, that is the vestibular portion. So these 3 portions are responsible for maintaining the afferent pathways of the cerebellum. So first 3 are very simple. They are cortico-pontocerebellar, cerebro-olivocerebellar, and cerebro-reticulocerebellar. The terminology is a bit tough because it is not used in routine. So we have to keep on practicing these terms so that we can become used to it. So cortico-pontocerebellar, cerebro-olivocerebellar, and the cerebro-reticulocerebellar, what is their function? They convey control from the cerebral cortex. All these 3. Now we move to the 4th and the 5th one. The 4th and the 5th one, as the diagram shows, the cut section of the spinal cord. So the information coming in from these tracts is from the spinal cord, from the downwards. So the anterior spinocerebellar and the posterior spinocerebellar tracts are there. So anterior one is conveying information from the muscles and joints. Similarly, the posterior one, which is taking same information from the muscles and joints. So spinocerebellar, whether anterior or posterior afferent pathway, they bring information from the muscles and joints. Now the sixth one is the cuneo-cerebellar. It conveys information again from the muscles and joint, but from the upper half or the upper limbs. The seventh one is the vestibulocerebellar. As we have seen the vestibular apparatus here, so it conveys information of the head position and movement. So this portion is actually responsible for maintaining the posture and equilibrium in connection to all other pathways. So the upper three are coming from the higher surface or the cerebral cortex. These three are coming from the spinal cord, and this one is coming from the vestibular portion, and it is conveying the information regarding head position and the movement. Other efferents are also there which convey information from the midbrain as well. So we have to remember this. So these are the afferent pathways and their functions. Now, again the same pathways, afferent pathways, from where they are originating and where they are ending. So we are talking about the origin and destination of the afferent pathway. So the corticopontocerebellar and cerebro-oliverocerebellar, they all arise from the frontal, parietal, temporal, and the occipital lobes. They gather information from all the lobes, and their destiny or destination is the pontine nuclei and the mossy fibers to cerebral cortex. And the cerebro-olivocerebellar pathway, it is coming from the same frontal, parietal, and temporal and occipital lobes, and it is ending up in the inferior olivary nucleus and the climbing fibers of the cerebellar cortex. Now the third one is the cerebro-reticulocerebellar pathway. It is originating from the sensory motor areas, and it is ending up into the reticular formation. The three anterior spinocerebellar, posterior spinocerebellar, and cuneo-cerebellar, as they are arising from the spinal cord, they arise from the muscle, spindle, tendons, and joints, and they are ending up into the mossy fibers to the cerebellar cortex. Vestibular nerve originating from the utricle, saccule, semicircular canals, and again their destination is mossy fibers to the cortex and flocculonodular node. Others from the red nucleus tectum, they also end up into the cerebellar cortex. So these two tables are very, very important about the afferent pathway, their functions, and their origin and destination. So we have to remember these two tables again and again. Again, in nutshell, the cerebellum afferent connections, we have corticopontocerebellar pathway, olivocerebellar tract climbing fibers from the inferior olive. We have spinocerebellar pathway, which is bringing information from the spinal cord, and the vestibulocerebellar pathway. And these are the connections which they make, and these are the peduncles through which they are passing. This is the superior, middle, and inferior cerebellar peduncle. So you can notice each and every afferent connection and their passage through various cerebellar peduncles. Now the cerebrocerebellum. So this is important. The cerebrocerebellum is concerned with the planning and initiation of movement and motor learning. So what does it do? It is associated with the motor planning and initiation. Motor learning occurs as a consequence of ongoing activity of the cerebellar parallel fibers, and the corticopontine fibers from the motor cortices project to the deep pontine nuclei. The pontocerebellar fibers decussate and enter the cerebellum via the middle cerebellar peduncle, and they terminate in the cerebral hemisphere or the cerebral cortex. Now, Purkinje cells project to the dentate nucleus here, and fibers leave the cerebellum via the superior cerebellar peduncle and project to the contralateral nucleus and thallus and the thalamus. And fibers from the thalamus then pass back to the motor areas. So, in order to simplify this, the cerebrocerebellum you can see this tabular diagram or the sequence. It is arising from the motor cortex to the pontine nuclei to the cerebellar cortex. In the cerebellar cortex, they go to the dentate nucleus. Then either they go to the red nucleus or they can go to the thalamus. Now, how the spinocerebellum works? Again, it is responsible for the motor activity of the limbs as well as maintaining the posture of the body. So afferent from the dorsal and ventral spinocerebellar, they reach in and enter into the inferior and superior peduncle. They project to the ipsilateral vermis and paravermal cortex. So in a nutshell, you can again see this tabular diagram. So spinocerebellar tract, they are coming into the vermis and paravermis. From there, they goes to the interposed nuclei. And what are the interposed nuclei? They are the globose and emboliform in between fastigium and the dentate nucleus. And they also give fibers to the vestibular and the reticular nuclei. Interposed nuclei, they either go to the red nucleus or the thalamus. From the thalamus, they go to the motor cortex. And from the red nucleus, they can go to the inferior olivary nucleus again and again to the vermis. So the last one is the vestibular afferent. Again, it is responsible for the conjugate eye movement and balance control. So this is very, very important because we all know that cerebellum is the actual thing which is maintaining the equilibrium. And equilibrium without having control on eyes and ears is near to impossible. So if someone is having eyes and ear in any organization, it means he is in control. So vestibular afferents are the main ones which are giving control to the body. And again, you can see in this diagram, the vestibular nerve from the vestibular nucleus and then the flocculonodular lobe in the vermis, and then it goes to the fastigial nucleus. Again, this whole tract is in the midline. Then fastigial nucleus, they go to the gaze center, vestibular nucleus, and the reticular nucleus. So vestibular afferents are responsible for the eye movement and balance control of the body. So when we talk about the efferent pathways from the cerebellum, so we have so many efferent pathways, but we have to remember these four efferent pathways. So these are the globose emboliform rubral. And what do? They influence the ipsilateral motor activity on the same side of the body. The second efferent pathway is the dentothalamic. It influences the ipsilateral motor activity. So both globose emboliform rubral and the dentothalamic, they influence the ipsilateral motor activity. The third one is the fastigial vestibular. It influences the ipsilateral extensor muscle. And the fastigial reticular, they influence again the ipsilateral muscle tone. So these are the diagrams of the efferent pathways from the cerebellum: globose emboliform, dentothalamic, fastigial vestibular, again and the last one is the fastigio reticular. Now these are the structures which are passing through different cerebellar peduncle. I will not go into details of these, but we have to keep in mind that again, there are three cerebellar peduncle. We have to keep in mind that these relay information from the cerebellum. Without them, nothing can go in and out of the cerebellum. So the superior peduncle is also attached to the midbrain. The middle cerebellar peduncle is just behind the pons, and the inferior cerebellar peduncle is a relaying station towards the medulla. So these all are the fibers which are passing through the superior cerebellar peduncle. So the fibers A are entering into the cerebellum and the fibers B are leaving the cerebellum. In the middle cerebellar peduncle, mostly there are some fibers. The most common one is the pontocerebellar fibers, and they are actually crossing the midline and they arise from the contralateral side of the hemisphere, and they go from the midline and go into the contralateral middle cerebellar peduncle. Similarly, as the superior cerebellar peduncle, the inferior cerebellar peduncle again is a very busy peduncle because it has these all tracks that are entering into the cerebellum, and these are the tracks which are leaving outside the cerebellum. So the important question is, why cerebellar pathology or anything which that happens to cerebellum causes problem in the ipsilateral side? So this is the most important question which we always encounter. So this happens because the pathway from the cerebellum to the lateral motor system and then to the periphery are double crossed. So there are double decussation. The first crossing happens as the cerebellar outway pathways exit the decussation of the superior cerebellar peduncle, and the second crossing occurs at the corticospinal and the rubrospinal tract, and that descends through the spinal cord. So first decussation and the second decussation. So the fiber which has started its origin from the right side went to the left side in the first crossing, and then again through the corticospinal rubrospinal tract, it descends in the spinal cord. Again, it decussates toward the same ipsilateral side. So this is the main reason why cerebellar pathologies are ipsilateral. Now let's talk about a bird eye view about the functions of the cerebellum. So cerebellum, it's a master when it comes to performing equilibrium, posture, and maintaining the harmony and synergizing each and everything in the body. So what does it help? It helps to control the tone of the muscle. It controls it controls the rate, it controls the range, and also the force and direction of the movement. This is called synergy. So it is the connecting factor, it is the synergizing factor which synergizes each and everything. Too much excitation, too much inhibition, cerebellum is there and it will help and maintain the synergy. It also controls the rapid muscular movement like running, typing. Uh, it is also controlling me right now because I'm talking. It is also helping in coordination of three activities, that is sequencing and correcting them. So if you are repeating things and you suddenly notice that you don't have to put more voluntary input into that skilled repetitive movement, this is because of the neural sharpening and neural motor learning which is done by the cerebellum. It also receives continuous update information for desired program of the muscle contraction as well. It also has some comparator function. It also has sequential movement when there is continuous movement going on, and sequence is also maintained by the cerebellum. It also help in the visual scene. So if an object is coming towards you and it's a fast moving object, or you are approaching in a fast speed towards anything, so it helps in the prediction of the change as well. So it alters itself and it maintains you in an equilibrium form. It also helps in applying brakes wherever necessary, coordinated movement, and helps in speech as well as posture and equilibrium. So this is all about the cerebellum. Thank you very much.
Thank you very much, Dr. Asad Ismaili, for such a nice talk on deep cerebellar nuclei, and starting with the gross anatomy and then about the gross, I must say, physiology. It was a nice talk, and before going towards the question answer session, I must congratulate both of you because preparing and presenting such neuroanatomy topics is basically, it requires loads and loads of hard work. So thank you very much to both of you. So questions from the participants? If you can type in the chat box, or if you want to be say something, we can unmute you. Any questions from the participants? Okay, can I ask a question from Dr. Yusuf or Dr. Asad? What happened if the lateral 1/3 of the cerebellum is during the surgery? We, especially in the CP angle surgeries, when the brain is tense, the cerebellum is herniating towards the incision site. So what happened if the lateral 1/3 of the cerebellum is traumatized? Any idea about that?
Yes, sir. Sir, actually, if we are talking about the cerebellar hemisphere, we are not talking about the midline, right?
Right,
As
right.
you said, we are doing CP angle surgeries. We are actually on the dealing with the cerebellar hemispheres, and we all know that deep nuclei, which is present in the lateral half of the cerebral hemisphere, it is a dentate one, and the dentate nucleus. Uh, it is responsible for all the motor activity which is input coming from the higher cerebral centers, and it is going into the dentate nucleus. So it can cause we all know that cerebellar mutism can happen, and motor activity and equilibrium can be disturbed.
Okay, thank you. Any questions from the participants? Okay, so if there are no questions, I think any final thoughts from Dr. Ahmed?
Thank you, and congratulate both speakers for fantastic presentations, very nice lectures, and very nice informations. And it's really, as Dr. Muhammad Usman said, it shows that you do very hard work for preparing for these presentations. So, Professor Riyad, final remarks. Please unmute, Professor.
I'm doing, but no. Okay. Thank you very much, Dr. Asad Ismaili, and he's a very competent person, very good neurosurgeon, and he has worked with me in Hyderabad also. And the way of presenting a very complex topic of cerebellum in a way of the three was very nice, and both of presenters were presenting very nicely. The question which asked by Dr. Usman that by traumatizing the cerebral hemisphere, most of the time when we retract, the excessive retraction is dangerous to any procedure. So intermittent removal of the retraction is necessary while we are performing a lengthy surgeries like the CP angle schwannoma or meningioma. So I think no neurosurgeon who is trained with the micro neurosurgery will traumatize the brain, except the excessive retraction can be harmful, and sometimes the patient may develop the opposite side weakness or such types of problems. So, Dr. Ahmed, today we are behind the not the behind the time. We are more gain the time. So 1 hour 30 minutes. So I think we should be within time. So what's the actual time? Is it the 1 hour or more than 1 hour we can avail?
No, we can, if we have the good discussion and good information, we can take
Okay.
more than 1 hour, no problem.
Okay. Okay.
I think
But the
we all
presentation
enjoy.
should be, yeah, but presentation should be of a 1 hour period. Discussion can be prolonged, but the presentation should be within either the single presenter or the two presenters. So it was a very nice talk, and the Yemeni Society and the other stakeholders are taking part. So this is a nice thing, a good academic activity. We appreciate that we can continue it for the betterment of our young neurosurgeons. Thank you so much.
Thank you very much, Professor.
Thank
So,
you.
Thanks a lot.
I think there is no questions, as Dr. Muhammad Usman said.
Yeah,
So
there is no
see you all.
question.
Okay, so see you all inshallah next week, where we will have two presentations. First will be about the anatomy of brainstem surface and divisions by Dr. I'tizaz Ahmed, and the second will be vascular supply of the cerebellum and brainstem. It will be presented by Dr. Ariba Tariq, inshallah. So see you all, inshallah, next Friday and same time. Thank you all for attendance.
Thank you.
Thank
Thank
you.
you.